and welcome to Inside Oncology, the podcast where we explore the medicine, progress, and human stories shaping cancer care today. I'm Poovenraj Kanagaraj, and today's episode is part of the Blue Cap Run 2025 awareness campaign organized by Yayasan Mr. DIY in collaboration with the Urological Cancer Trust Fund, UCTF, and supported by KALSIS along with other valued sponsors. We are here to talk about prostate health in Malaysia, why awareness is low, why early detection matters, and how families can be better supported medically and financially. Prostate cancer is one of the top 3 cancers among Malaysian men, accounting for nearly 6% of all male cancers. The number of new cases has more than doubled over the past 2 decades, yet many men are still diagnosed at later stages when treatment is more difficult and costly. Joining me today are Professor Dr. Teng, consultant urologist at University Malaya Medical Centre and committee member of the Urological Cancer Trust Fund, and Mr. Jonathan Teoh, founder and CEO of KALSIS. Welcome, gentlemen. Thank you for being here today. Professor Ong, perhaps you can start off with a bit about UCTF. What's it all about? What's your mission as well? And what are you doing to raise awareness on prostate health in Malaysia?
Right. Thanks a lot, Raj. So for the UCTF is a Urological Cancer Trust Fund. Of course, when we talk about urological cancer, there are various kind of cancer affecting the urinary tract, all the way from the kidney to the bladder to the prostate. But in Malaysia and worldwide as well, I think the most common urological cancer is prostate cancer. That's why the emphasis that we put a lot upon is on prostate cancer. And for Malaysia, I think prostate cancer is number 3 in terms of the most prevalent cancer for men. It always been that high a prevalence, and in many countries it could even rank number 2 or number 1. So the disease burden is there, and that's why we are paying attention to that. And the role of the UCTF when it comes to prostate cancer, meaning we call it the ACE approach, the ACE approach. A stands for awareness. This part of the effort now, we're creating awareness. The 3 of us here doing this podcast is to, so that people know about the disease, know how to detect early, so to get the best outcome. That's the A part of it. And the C part is to going to the community when we have some project, then we go to the community. For example, this Blue Cap Run, to tie in the community. And then the E part is the education, not only to the public and also to the healthcare professional. Like many of us are healthcare professionals, the doctors, the paramedics, the nurses. We should know more about prostate cancer, how to detect early, and how to go about telling people how to come forward. So these are the role that the UCTF plays.
Yes. Reports have shown that prostate cancer cases have steadily increased, but public awareness remains among the lowest. You obviously have a myriad of cancer types in Malaysia, and of course you see months like October very focused on breast cancer.
Yes.
And of course you come to November, then there's November,
Yes.
basically focused on prostate. But would you say the traction that other cancers tend to have more highlight on them compared to prostate? And why is awareness relatively low?
Yeah, of course there are many reasons, why prostate cancer is more quiet and less known. Because one reason is occur in the older age group, and it affect only men. And we know the man health-seeking behavior, they're different from the female. A lot of men are shy, they don't want to come forward, they will probably keep everything to themselves. So that caused the delay in diagnosis and the low profile of the disease. So of course, in comparing the prevalence in overseas, the Western country, the prevalence higher. So in terms of prostate cancer, so for example, this Movember movement from Australia. So Australia have a very high incidence of prostate cancer. So they have one group that created this initiative to create this Movember, which has a very high impact in terms of patient education, in terms of pushing frontier research in prostate cancer, in terms of diagnosis and treatment. So similar Movember kind of movement and initiative and awareness, it could be pushed in Malaysia as well. That's what we are all working towards.
How does this impact early detection? when men are shy to come front, how can it impact? How does it affect early detection? And as a urologist, do you see over the years that you have been and the patients, does it get better? Do men actually feel less shy now compared to maybe 10 years ago?
The straightforward answer is men, I think, are getting less shy, which is a good thing. With all the effort that's been done for the last 5 years, 10 years, I think men are more forthcoming. So I think we could improve that further with all the continuous efforts from all parties. We could improve that further. So the awareness is important, like we have mentioned. I think there's way to detect prostate cancer early. For example, a blood test for prostate specific antigen and so on. So there are ways to detect that early. And we know from statistic kind of survival analysis, if we detect that early, the 5-year survival, is more than 90%, which is fantastic. It is fantastic. But if we diagnose it at late stage, stage 4, when it has spread, the 5-year survival is less than 50%. So that makes a big difference. And for Malaysia, for example, if 100 new patients are presented with prostate cancer, 50%, half of them are in stage 4. Which is a very significant kind of negative finding. We shouldn't get so many people with stage 4 disease when in developed country, the advanced developed country, only 5 or 10% of their patients present with stage 4 disease. So 10% in Western country, developed country, and we are 50%. So we have a huge gap to close. But of course, we can do that to close the gap.
For 50% of patients to appear at a stage 4 BLC, could we say that they're actually ignoring the symptoms and signs of stage 1, stage 2? And what makes them feel this is not cancerous, but this could be a day-to-day, what is the conversation that you have with these patients?
It could be. Some prostate cancer are asymptomatic, meaning without symptom. So we can't blame that patient for not coming earlier. But some do have some symptom, like slow urinary flow, frequency, urgency, having blood in the urine, and so on. So when they are symptomatic for their urinary tract, they should come forward. So when they come forward, the healthcare professional will do all the history taking, examination, the blood test involving the prostate-specific antigen, the PSA. That can be done. All right, so that's just one thing. And then number 2, another risk factor is a patient with family history of first-degree family history having prostate cancer, or for they are at higher risk. They should come forward for early screening. So there are many ways that could be done. So the education part is to the public, to the patient, and also the healthcare professional. When the patient have this kind of symptom, a family history, I should pay more attention. So that education part on and reinforcing that information for the healthcare professional to we ourselves. That's important as well.
So let's refresh the signs and symptoms again for men. It could be fathers with young kids, young children who may be watching this, young boys, teenagers. What are the early signs and symptoms that we need to be aware of to refresh?
So as I said, most of them have asymptomatic, no symptom. Well, that if there are no symptom, that's a different category. If they have symptom, normally it's above age of 50 for men. We call that lower urinary tract symptom. The short term is short form is LUTS, lower urinary tract symptom, meaning in terms of urination, they could have slow urinary flow, hesitancy, intermittent flow, and then they could have urinary frequency, meaning go to the toilet many times and find it difficult to empty, urgency, nocturia, which is having to wake up at night to pass urine, that affect the quality of their sleep. If they have any of these symptoms, of course, they should be alert and seek for medical advice. Of course, more alarmingly, they would have blood in the urine, right? But this could still be early sign. Yeah? If we go to see the healthcare professional early, we probably could catch things early. But if the disease has spread, to the other part of the body, because prostate cancer like to spread to the bones. So when they have stage 4, they sometimes present with bone pain, tiredness, lethargy, but that's probably kind of a late presentation. We don't want to wait until that part. We want to diagnose it upstream early. Yeah, we can detect it early. What survival is fantastically good. Yeah.
So let's talk about these tests to detect early. So I'm going to break it down to a few parts now. There's obviously patients who already have signs and they come into your clinic and you're going to present them with a few tests. Can you run through what are the tests they'll actually have to do and how effective are these tests?
Yeah. So the test, when it comes to tests, of course, it will be best if you got the magic test, One test that will tell everything, but there's no such magic test, I think, in this world, All tests is false negative, false positive, So there's a lot of give and take there, yeah. So for prostate cancer, most important, like we have mentioned, is the history taking of the patient's symptom, family history, and so on. And the doctor could do a digital rectal examination to examine the prostate. So with a normal prostate is smooth, prostate with cancer a bit more rough, kind of thing. Yeah? Then when it comes to the so-called test, there will be this blood test, which is called prostate specific antigen, PSA, which is basically only detected in male. Yeah? So when it is elevated, there is a possibility that the patient might have prostate cancer. So it's quite a useful test because it's very specific to the prostate. So when the PSA level is raised, we know that something is wrong with the prostate. Yeah, the only thing is that, when the PSA is high, it doesn't equate to cancer straight away, because many other conditions could cause a raised PSA, the prostate-specific antigen, such as if the patient have a urinary tract infection, have a benign enlargement of the prostate, or ejaculation, and so on. That will, kind of elevate the PSA, the blood test result. So the healthcare professional have to see on a case-to-case basis, and do further tests to see whether that raised PSA is indicative of a prostate cancer. But the naysayer will tell us that, there's no use to use PSA, it's useless, A lot of people will say that, but I think that's not true. It's still very useful, It's one very important diagnostic component. We'll add on to the history, to the examination, and combine all together, to give the correct diagnosis to the patient, and to catch the disease early. So it is still very, very useful.
So let's talk about a man who may not have the symptoms. Let's mention this asymptomatic situation. But let's say I'm over 40, and I have a family history. Well, my dad, my grandfather, they all have had early signs of prostate cancer, but they're detected early. But I don't present with any sign of. Can I still come in for screening? We are always talking about above 50, but those below 50, what's the prostate cancer signs and symptoms are range of, can they come in for an early detection screening as well?
Got that. So when just now when we talk about those patients with symptom, when they're symptomatic, I mean, we have to go all out to investigate and do a proper investigation to see what is the underlying problem. So what Raj had mentioned is another group with no symptom. They're all well, right? I'm past urine, no problem. I don't feel any problem to wake up at night or to go toilet very frequently. I don't have all those symptoms. So when they come to an asymptomatic patient with no symptom, that comes to be the issue of screening. No symptom, we screen, right? Shall we screen or shall we not screen? Right? That is the debate point. That is the point for debate, because mainly there are two big trial, trying to prove the benefit of screening a population with no symptom. One is an American trial one is a European trial. The American trial was negative, saying a screening might not be too much, bringing too much benefit. Whereas the European trial, it shows that if you screen a population with no symptom, it actually brings a lot of benefit in terms of reducing the risk of death from prostate cancer. So it shows benefit. So there's still conflicting result from the trial. Yeah, of course, the American trial later was kind of criticized for contamination of the trial population. So the general feeling, there are a school of thought saying there's no point screening. There's also another school of thought that if we do smart screening, targeted screening, it will bring benefit to the patient. That's what we believe. So in terms of age, in the general population, we know risk, no family history. We will say you can start screening from the age of 50 onward up to the age of 69, 70, that 20 years. So that's a general understanding. If we have family history of prostate cancer, the screening can be brought forward by 10 years. Meaning start from the age of 40, 45, we should start screening. So that in terms of age. What do we do during screening? That's another kind of a contentious point. Of course, the most common test we could do is PSA at this moment. And some people will do an MRI scan of the prostate, but that is costly and not easily accessible. So I think at the moment, PSA is still a very relatively cheap test that we can do. Of course, if future research show a better test than PSA, that would be fantastic. That we could pin down it even more accurately.
We obviously spoke about early screening, and then we touched a little bit on stigma as well. But from my understanding, when you mentioned 50% of cases come presented with stage 4, when you are shy or you feel your masculinity is sort of endangered when you want to go and do your exams. But when you appear with a stage 4, obviously then costs are much higher. Right. And I'm going to give you a bit of a break now. Jonathan, right? So when treatments get a bit more complex, it's no longer just for screening, early screening. It's no longer just for having a consultation and saying, okay, this is stage 1, but these are 50% of cases are stage 4. Are people aware of the cost involved that appears in this? And do you think education should also touch that if you're presented with stage 4, it's a lot more expensive than compared to stage 1?
Correct. And it's something that we have already seen from previous examples of podcasts on other cancer indications such as lung health, which shows that an early stage diagnosis can be addressed for less than 10,000 ringgit as compared to stage 4, which is obviously hundreds of thousands. The same could be said true for prostate cancer. But what we want to always share is that because prostate cancer is a lot more survival, there's a lot of options available where people could even look at more exotic, not exotic, but rather more advanced therapies like robotic surgery, which is heavily promoted. That maybe something that Prof can help us unpack on the benefits of robotic surgery vis-a-vis conventional surgery. Because that's the cost component to that. And I mean, obviously we see hospitals packaging all these based on very strict parameters. That's one thing that is something that patients may want to consider, but whether it confers a better quality of life post-surgery is something that maybe Prof can help us unpack. But the other part we're seeing as a result of half of the patients population being diagnosed at stage 4 is this thing where what happens when conventional therapies start to lose its efficacy, especially for castration-resistant metastatic prostate cancer. And this is where we're seeing a radical new frontier opening up called radioisotope therapy. This is something that has only emerged in the past few years, I believe, but it's very expensive because what it means is that it's practically using a PSMA to look at, which is an imager that that once you is inside your body. It's lit up, and you know where your cancer is. So the theory is, if you could pair this imager with a radioactive isotope, bind it together, and inject it in the body, it means that whatever you can see, this imager paired to radioactive isotope goes and seeks out all your cancer cells across your body, including the bones, and attaches it, and it irradiates the cell and makes it go away. And the early indications show that, hey, it's a very, very promising, very promising field, especially when then no conventional therapies left available, but it's phenomenally expensive, but luckily we have hospitals already in Malaysia that's offering this, but the cost is not cheap, and it's driven by the fact that it requires very specialized handling of radioactive items. You can get it from a reactor, first of all. You have to transport it to the hospital. You need to have specialist staff that knows how to handle it and to dispose of it. That's why it's so costly. But it really has an effect. And maybe something that Prof can unpack, because these are all very exciting frontiers, but requires money to address. So we rather see people at an earlier stage where it's less costly, but we also acknowledge that half of the population coming at stage 4 means that we have to address this part also, which is where KALSIS exists.
So what is KALSIS's role here in terms of addressing these gaps, right? You mentioned, it's expensive, and it's expensive for a reason, because there's so many layers of expertise required just for transportation, to manage, to deliver a very positive outcome, and hopefully a very positive outcome. So where does KALSIS
Yes.
appeal here? And how can you help?
So where we come in is our mission, which is basically 2 parts. One is to improve healthcare access for seniors, and second thing is advanced secondary prevention through what we're doing here. Where we are today is that, overall, more than 65% of seniors or people diagnosed with cancer are often late stage, requiring complex treatments, and often not. It hits seniors disproportionately because, first of all, they have left the workforce, so they don't get covered by insurance, or nor may they be able to afford continuous insurance cover, which is now getting more costly, and they may have limited retirement savings because that's all they have saved up. So what happens if they know that they have got cancer, but treating it will wipe out their entire savings? That will put them to what we call financial toxicity, which is something that's no coming back. So we needed to develop a better way to fund this, but not rely on government, and obviously not rely on insurance. And this is where seniors can tap on the value of the homes to fund not only the immediate healthcare needs, but then the retirement costs after. Because why we see this as very important is that they need to have, ensure that they have sufficient funds to always go back to the doctors for continuous monitoring and be able to address anything should it pop up again in the future. That's the reason why we designed this, but from a capital markets perspective, so that it comes from a different source of institutional investors behind this to fund seniors. As a result, create positive outcomes. And so it's a very new scheme in Malaysia, but it's being done in partnership with Kanagaraj Investors Berhad, with very large institutional investors behind us. So that's why we can provide the capital needed upfront, but yet also sustain a person's lifetime needs without them having to move from the home. That's the most important thing. So this helps us in a way that now we've got this solution on the table. How do we then all work together? Because we all know that affordability is an issue. So the main thing is to then work together beyond just the clinical sphere, but be very inclusive. Where capital markets work with NGOs such as NCSM, but also with clinicians and also advocates like UCTF, so that together we can pool our resources to not only put more options on the table, but to advance secondary prevention so that we don't have to wait till it's late stage, come and get it early and address cancer early. And as a result, you can just, get over this hump and live your best years ahead. in retirement.
Thank you. And have we deployed the scheme already?
It is already live. Yes.
Lying so far.
It's actually been very positive because when people see how safe the scheme is and how we designed it, because again, this is a space that's heavily regulated by the capital markets. And of course, we have our friends in the industry and in the regulatory circles that are watching this with great interest because, and we are bringing in all the feedback to make sure that at the end of the day, we protect the people who we care for the most, the seniors. And as a result, what was like to share is that the reception has been very positive, especially in the NGO circles, because they see us as bringing valuable resources that has never been available, but yet in a new way of doing things, so that together we can maximize impact exponentially rather than business as usual, where we can only reach a certain community. So the things we're doing now reaches more than our immediate addressable networks, but by working together, this is all possible.
Thank you. Prof, back to you as well now. Of course, when you know, with us being in October, and you've got teams here who have basically on the ground doing clinical press examination. Yeah, the reception is there. And when people hear mammograms, it's already action now, sort of birth in our heads already, right? That okay, it's October,
Yeah.
it's gonna be free programs. We're gonna do. What's that? Are we duplicating that for prostate health? Do you think efforts, there are great efforts already, or should we do more? Because we are obviously working in partners like KALSIS to raise awareness. What's the efforts like in this landscape now to really raise awareness on making sure that our men think of prostate health as part of their yearly must do?
I think that's like you have mentioned, we know about other kind of the screening program, the breast cancer screening program, cervical cancer screening program, and so on, right? Well, the prostate part, I think we have much work to be done, right? We have all this health promotion, awareness campaign of prostate cancer. I think various NGO, including Prostate Cancer Society Malaysia, UCTF, and also the Ministry of Higher Education, and also especially the Ministry of Health. Ministry of Health, the various hospital with urological service, they are doing yearly kind of prostate awareness campaign and to screen the patient. So it has done in various levels at different times of the year. Of course, that could be kind of elevated and be more widespread, with more funding and support from the various sponsors, the NGO, and also from the government. So there's one aspect. Then another aspect is to, of course, create awareness also among the healthcare professional on how to deal with a raised PSA, right? So if we have the healthcare screening program and find that there's abnormal prostate specific antigen, how do you deal with that, right? So the healthcare professional must be ready to deal with that. So the family medicine, family physician, the FMS, and all the GPs of Malaysia, they have to learn how to deal with abnormal prostate-specific antigen or patient with lower urinary tract symptom and so on. That is why one of the contribution of UCTF is to be created a module, an online module called PCAT, on kind of spread the knowledge on how to deal with the patient coming with a raised PSA and so on. So that module is available for free. So the continuous effort towards that, we could improve the module, to more content rich, to cover more aspect, so that would be fantastic. One other aspect which is very important for Malaysia, so if you have a raised PSA, you got more prostate cancer coming through with early stages. So the urologists and the oncologists and so on, we must be ready to deal with that, right? So at the moment, we know there's a lack of specialists in this country. We are short of specialists. So the training of specialists, that effort need to be kind of speed up. So we get more specialists in terms of urologists, oncologists, to cope with the rising cases of prostate cancer. So the training part is also very important. As we know, the number of urologists in this country is about 150 to 160. So the number is still very small. Same with oncologists as well. So this aspect, I think the training body, the government really have to look at it very seriously.
You've seen in other countries where prostate cancer screening and treatment are part of a very structured national health program.
Yep.
What's that like here in Malaysia?
Yeah, at the moment, so it is not in every screening program in terms of putting a PSA test into that, right? So there are proponents or people who say, yeah, we should put into that. There's another group of people say, no, we should not put into that. Yeah, so that's kind of an argument there. But the proper way to do that is called target screening of the age group that we have mentioned, 50 to 69, 70. On those with family history, you screen 10 years earlier from 40 or 45 years old onward, and that is number one. And number two, of course, this, should be made available and for the patient in terms of cost and all that, to be packaged in. And then another factor, first, availability of the second one is what we call shared decision making, or which is emphasized in the teaching module, that the patient understand that, hey, you are being tested for PSA, if it is normal, what should we do? Is abnormal, what should we proceed from there? So that kind of education need to be done and to be made available for the patient. Patient should know that, oh, I'm going to have a PSA done, right? So that kind of shared decision making. So that is another keyword. So that will enhance the screening.
Well, I suppose the next question is for the both of you as well. Having worked in corporate, of course, health screening packages, we've got covered part of the corporate benefit. And so we've just starting to our blood tests. Are PSA tests part of this in usual corporate packages, or do you have to request it as an additional?
Yeah, it depends on the organization. Some already package it in, for many screening program is already in there, right? So some don't have it there, So I think the proper approach is that we should include it in, but we inform the patient. Mr. Ahmad Ali or Mr. Lee, Mr. Mutu, we are going to add the prostate cancer screening test in your package, So we should inform the patient so they understand that. And that should be included in that entry criteria, inclusion criteria that we mentioned.
So what are your thoughts on this employer-led screening benefits, including prostate health screening into this? In your experience, you obviously speak to corporates, are they doing this, or, do they feel it's not necessary now?
So for GLCs, there are system processes by HR where your screening benefits are pegged to, first of all, your position, but also how much is available. And what we've seen typically is about 2,000, 3,000 as health screening package. But what we want to advise people is not to just go to the most expensive hospital because you can just spend it, and because at the end of the day, all these screening packages are more or less standardized, but rather read up on all these protocols they've listed there and identify where there are gaps, because there are hospitals that can offer the same health screening package for maybe 1,000 ringgit, and you could then use the 2,000 that you not utilize for other things that you should then look for, especially for those that are your middle managers, like from the 40 years onwards to senior executives. Don't leave this to chance. Read up on what you should look for, because there's always the over-reliance that you're so busy that you just defer to the executive premium platinum health screening that you've believed covers everything, but not really, because it could just be the hospital offering this at a specific price, but may miss out on a few key items.
Okay, I suppose as we get to the end of this conversation, I suppose, and it's open to the both of you as well. what is the one message you want Malaysian men and their families to take away from this conversation? Whether it's about screening, early detection, even being very financially prepared. Right? It's not just about having saved up money, it's about knowing what are the options out there to help you out. What is the one message you would have along?
I think the most important thing is that, early detection is available. Yeah, I think that's the most important message. Yeah, and then if we detect early, the outcome is fantastic, right? So I think we could help ourselves if we are the patient, or we could help our family, yeah, our father, our close relative, to help them to detect early. Yeah, I think that there's great hope in improving the care for prostate or prostate cancer in this country.
Yeah. I would say that for prostate cancer is, very survivable, especially early stages. But at every point, stage 1 to stage 4, there are always trade-offs. So in the sense that if you're early stage, the trade-off is you need to make sure that you are very well versed and ensure that, especially you've got a family history, and to go and present early for health screening, specifically, targeting this. But of course, then if let's say you come at a later stage, stage 4, there's still a lot of options on the table. I was hoping then maybe Prof. Ong can talk about robotic surgery and even radioisotope, because these things are offered, but to a lot of people is it worth putting money behind this, especially with what do I get as a quality of life? Because I value that. I've been told that even at stage 4 is 50%, chance at a 5-year survival range. That's pretty good, for in terms of cancer landscape. So, but then is it worth spending the money? So maybe it can help unpack that as we wrap up.
The term robotics, it's becoming increasingly popular among not just in cancer, but in the other areas of expertise as well. What's that like? Do people come and ask you, if I'm at a stage where do you have robotics?
Yeah. Robotic is an instrument that help the surgeon do the operation. Yeah, they are used in various fields of surgical endeavor, orthopedic, general surgery, urology. It's especially useful in prostate cancer. So it's called radical prostatectomy or robotic assisted radical prostatectomy. So we use the surgeon use the robot, so they can have a kind of a 10 times magnification of the operative field. And the robotic arm can go to a very deep, narrow pelvis. So make the surgery actually easier. Yeah. But the outcome of the surgery, of course, is very much dependent on the expertise of the hospital, of the surgeon, because the robot is the tool, yeah. So it very much dependent on the person who use the robot. Like they used to say in the Top Gun movie, it's not the plane, it's the pilot. So if you find the correct pilot and the pilot can fly that plane, which is the robot, well, then the outcome will be good. Yeah. So it all depends. Yeah. So some pilot can do keyhole surgery, even open surgery very well. Yeah. I think the outcome is good as well. Yeah.
Would you say it serves as a tool that complements the skill?
Exactly. It complements, it enhances our skill because of that precision tools. Yeah. It is good to have that. Yeah.
And then can you maybe share a bit more about radioisotope therapy, because it's so new, so interesting, but I mean there's not enough literature, so maybe you can see.
So yeah, there are various type of treatment in this disease spectrum of prostate cancer, from very early one till to the very advanced stage. The one when we talk about robot is an early stage, localized disease. So there are options: robotic surgery, open surgery, keyhole surgery, or radiotherapy, focal therapy. Some even very early cancer, we should just say observe them, of which we say that active surveillance. That's early stage. When it come to the late stage, the main core of treatment will be hormonal therapy, plus some kind of they call it ARPI, advanced hormone treatment. And if that process progress further, like Jonathan had mentioned, the CRPC, castrate-resistant prostate cancer. So there are chemotherapy option and various other options. And one of them is that radioisotope treatment. example, lutetium treatment, which is proved to be effective in that advanced disease, but the cost is very high. I think easily, if the patient can tolerate the whole cost, it's probably cost them ringgit, yeah, or even more. So that kind of a financial toxicity will come in at an advanced stage. So that brings us back to the message: detect early.
Yes.
So we won't have to come to the very end of it, where the cost is very high and the quality of life is not so great. So all the effort, we should aim to detect early as well. Yeah.
Thank you.
Right. Thank you.
The message is clear: early detection saves lives.
And saves money too.
Yes.
Community initiatives like the Blue Cap Run 2025, we can help more men talk, test, and take charge of their prostate health. To our listeners, sign up, donate, and encourage the men in your life to get screened. I'm Poovenraj Kanagaraj, and this has been Inside Oncology, brought to you by Cancer Matters. Thank you.